Hey everybody, it's Dr. Wood, and today we're going to cover our ENT medications here, right? So first off, I want to talk about antibiotics. Funny aside, I'll let you know that when I first learned about ENT providers, ear, nose, and throat providers when I was a young child, I actually thought that doctors just got to pick like random body parts that they wanted to cover. So I thought you could be like a knee, ear, and tongue doctor. And then I later learned that was a very poor sort of assumption on my part. Anywho, getting to the antibiotics that you frequently see being used in ENT purposes. So the nice thing about this section here is we already covered most of the antibiotics, and so I don't need to kind of belabor the points about how they work and all these different things here. I can mainly talk about their application for these specific indications. So starting off with acute otitis media, you tend to find that a lot of these can be viral. However, there is a strong overlap between bacterial and viral, and so again, when you have a strong suspicion that there is an infection here, very frequently it gets treated with an antibiotic, right? And so you're going to find that the spectra of bacteria that could be causing issues here, and you're going to see these big three come up pretty frequently in this section: strep pneumo, H. influenza, and then Marxella catarrhalis. These are going to be the three most common ones you're going to run into, and as such, most of our antibiotics will cover these three, right? But we're going to see the etiology changes over time, especially as things like vaccine rates change, especially as things like resistance rates change. You're going to find that this may alter, but this is mainly what you're going to run into. So the mainstay of therapy here is going to be high dose amoxicillin, right? So we're dosing like 80 to 90 mg per kilo per day. Note here that I am not necessarily going to be hitting you up on doses so much. I'm not going to have you memorize the dose specifically for my test. However, I want you to understand, like, why do we even need the high dose amoxicillin? In this case, because we're trying to treat the inner ear here, it can be difficult to penetrate, right? So because of that, that's why we have to shoot for higher doses. So especially with the increase in resistance, because this is such a common pediatric sort of infection, you got to shoot for those higher doses to overcome those or to get the right kind of concentrations there in the inner ear. Specifically, strep pneumo is a big one you're worried about because it does get pretty resistant with kind of over implementation of antibiotics. Now, you can use amoxicillin by itself. Remember, that's an aminopenicillin. However, if resistance is an issue, or maybe if the patient's been receiving antibiotics in the previous month or so they're having a recurrent otitis media, this is where you can find that we can bump up therapy with using something like amoxicillin clavulanic acid. It's an augmentin. You recall clavulanic acid or clavulanate is just a beta-lactamase inhibitor. So again, it helps to overcome the beta-lactamases that strep pneumo may be producing, right? If you had a patient who could not receive penicillins due to allergy, this is where you could switch over to something like a third-generation cephalosporin, like Ceftonir is a really good option here. So Omnicef is great because it's orally available, or azithromycin. However, I'd probably avoid azithromycin in a lot of patients, mainly because a lot of the strep pneumo out there is resistant to macrolides. And so, sure, if it's an H flu, it may be treated okay, but in the case that is a strep pneumo, you're going to find that's probably not going to be that effective. And this is not something you typically culture very frequently. Maybe if the patient has tubes, or maybe if the TM is ruptured and things like that, you might culture it. But this is something we typically just use empiric therapy, and the patient gets better, then we kind of have our answer at that point. So it's hard to know whether they're going to have a resistant strep pneumo or not. Okay. Typical treatment time is not super clear, but it could be between, say, 5 and 7 days. For more severe disease, though, you tend to err on the side of treating for longer, so 5 days may not be sufficient for them. So again, usually between 7 and 10 days, depending on the case. There are more mild cases, 5 is probably fine. So say the patient, they came in to see you at the urgent care clinic, they saw you at the ER, if the case may be, and you sent them off on their merry way with that amoxicillin prescription, and then they came back and the kid's still miserable, still febrile, ears still looking terrible after 3 days or so. So in this case here, if there's been no antibiotic usage within the past 3 months or so, you could move up from, say, amoxicillin up to augmentin there. That would be reasonable. However, you may also want to consider something like a third-generation cephalosporin. Mainly Ceftonir is going to be the most common one you're going to run into. This is actually nice because it's available as a once daily dose, very similar to how ceftriaxone is as well. However, say for instance the patient is not able to tolerate oral medications, you may have to escalate with the more parenteral sort of therapy here. And so in these cases, we'll actually use ceftriaxone, either IM or IV. And so it's not uncommon. It's more rare than not, but you're going to find that it is not super uncommon that patients will say have to come back to the urgent care clinic or the ER. They'll actually come every day for 3 days and getting IM doses of Rocephin there, right? So moving on from that into bacterial rhinosinusitis, this actually has the same bacterial coverage as AOM. However, some other causative agents could include things like Strep pyogenes, Staph aureus, gram-negative bacilli. But you still have those three main respiratory bugs like Strep pneumo, H. flu, and Moraxella catarrhalis. Now, keep in mind that a lot of times it is very difficult to determine between viral and bacterial causes for rhinosinusitis, and very early on, it's very difficult to say whether the patient has a bacterial infection or not. Some things that lead you to think that it could be more bacterial is if they have symptoms, say, for a long period of time, say like greater than 10 days. If they had worsening symptoms at around the 5 to 6 day mark, it's called this resickening that occurs. That leads you to more think it's bacterial. So if a patient comes in, they're like, oh yeah, I got sinusitis, I've been symptomatic for 2 days, that's a little bit more of a hard sell. You may not want to go ahead and treat with the antibiotic right off the bat there, but they come in, it's been like 11, 12 days, and they said, oh yeah, I just got, especially a weekend, started to get way worse. That's something you want to think it's more bacterial. Now here, because of the high resistance of H. flu, we actually want to go ahead and just skip amoxicillin altogether and actually bump it up to amoxicillin, clavulanic acid, or augmentin. Basically, we can overcome that beta-lactamase production and that H. flu by using clavulanic acid, right? Now, if you had a patient who could not receive, augmentin because of a penicillin allergy, this is where you could use something like, say, clindamycin plus cefixime. Again, clindamycin is going to have some broader gram-positive coverage to get stuff like Strep pyogenes and Staph aureus, so you can use that in addition to something like cefixime, which is going to get most of your coverage, like your Strep pneumos and H. flus and all that. Or as an alternative, you could just use something like levofloxacin. Now, as you may recall me saying, Levaquin is a very good drug. It's one Q24-hour dosing, but it gets overused very frequently. So again, resistance can be an issue with that. So something to note. Here you want to know pediatric patients require a longer treatment time. Again, the sinuses can be somewhat difficult to treat in some cases here, or difficult to penetrate in some cases. So peds require longer treatment times, say 10 to 14 days. Adults more like 5 to 7. And actually, a lot of times we'll tell patients that they're really early in presenting and we're not so sure it's a bacterial cause. We'll actually tell them to use some of these saline irrigations. And again, there's no way you can do this without looking super awkward. But by using saline irrigations, it is important to that helps kind of clear things out a little bit and hopefully helps to allow for better drainage of the sinuses. And they found that being very good for symptoms, especially a lot of that nasal pressure and things like that the patients feel. Very important to note the kind of solution, the water you're using in here. They really don't want to use things like tap water or random sources because they're having cases of things like parasitic infections that have developed from that, things like Naegleria. Just things like deionized water or sterile water for irrigation can be used as a good alternative there. Moving into acute pharyngitis, you're going to find that very frequently this is going to be viral in nature. However, we have the group A beta hemolytic strep, the GABHS, causes about 15 to say 30% of cases here. And again, this is another primarily pediatric sort of indication. You're going to find that the big thing here is we don't really care to treat the bacteria because some people just colonize with the bacteria and it doesn't really cause a whole lot of issues. The main thing we're trying to prevent here are these suppurative complications, and namely chief among those being the acute rheumatic fever, because that can lead to things like cardiomyopathies and valvular issues and whatnot. So because of that, it's really important that we go ahead and make sure that we treat that to prevent these suppurative complications. Now, what we tend to do nowadays, because we have a rapid strep test, you can just basically swab the throat and have a test done very quickly to say, hey, we think this is group A beta hemolytic strep or not. You're going to find that that's not always perfect, and so sometimes you'll have some false negatives. In which case there, what we'll go ahead and do is we will go ahead and get a culture at the same time, and so if the rapid test comes back negative, we'll still run the culture, and then if that comes back positive, we'll call the patients up later on because it takes 2 or 3 days and say, hey, you actually do have an infection. We want to go ahead and give you antibiotics to treat that. One thing you can get away with here is just straight amoxicillin. And now remember, I said amoxicillin is actually a time-dependent antibiotic, usually given, say, twice daily. This is a case here where you're shooting for just once daily dosing, which is really good from a compliance standpoint. Another case you could use if a patient could not take oral, because again, this is strep pharyngitis, so it may be difficult for them to tolerate oral. You can use that benzathine penicillin G. If you remember, that is that one that came in that nice white milky sort of solution that's available for IM only. Because remember, it's long acting. It's Bicillin LA was the brand name. And so we can just do a one-time dose of that, and that gets the same sort of coverage as 10 days worth of the amoxicillin once daily. Really good benefit, a good alternative if they cannot take oral. So what if they have a penicillin allergy? You always want to have a backup. This is where something like cephalexin, the first generation cephalosporin, is great. Clindamycin's fine. Azithromycin's all fine here. Remember that there's always going to be reactions you have to worry about, side effects and whatnot. Usually cephalexin is going to be the most well tolerated. And remember, just because someone has a true penicillin allergy, very unlikely they're going to have any cross-reactivity with something like cephalexin there. So one thing to note, one thing it may be safe to use. This is something you may want to do like a test dose in the ER. So what are some other ways we could actually treat this? What are some more local ways instead of giving systemic antibiotics? And so very frequently our otic antibiotics are going to come as a combination of a antibacterial agent along with a glucocorticoid. Now, when I say glucocorticoids, I'm sure you've learned this already in places like physiology. Our stress steroids kind of come in two flavors, things produced by the adrenal gland. There's the glucocorticoids, which are mainly helping with things like glucose homeostasis and things like that. And then there's also the mineralocorticoids. Mineralocorticoids are more responsible for the things like water balance. It's like aldosterone is a strong mineralocorticoid. However, things like, say for instance, hydrocortisone or dexamethasone, things like that, those are what we consider to be our glucocorticoids. And so those are going to be better for their anti-inflammatory sort of properties there. And so again, the benefit of using the combination of an anti-infective plus a glucocorticoid is it will inhibit the bacterial growth and also decrease those inflammatory cytokines that are being produced there, and really helps with a lot of the symptom relief the patients are experiencing. And so some of the ones you're going to find pretty commonly used include things like ciprofloxacin, the combination of ciprofloxacin plus dexamethasone, which we call Ciprodex, neomycin, which is actually going to be an aminoglycoside. We're going to have polymyxin. We mentioned polymyxin in the last lecture. Hydrocortisone, this is the steroid here, right? Dexamethasone is the steroid here. It's called cordysporin. And then sometimes you'll just find ofloxacin by itself. This is actually the racemic mixture related to levofloxacin. So what are the cases we're going to use this? For otitis media, occasionally, more often than not, otitis externa are going to be the main utilizations here. Some special notes to make mention of is that neomycin, it's an aminoglycoside, does have the highest chance for hypersensitivity out of the group. So if anyone's going to have a reaction to something, or if they have a history of a reaction to something, it's probably neomycin. It's one thing to note there. Polymyxin B is not recommended for patients that either have tubes in place or if they have a ruptured TM. If you recall, back when we talked about polymyxins back in the antibiotic lecture, you'll recall that it had a issue of causing neurotoxicity and ototoxicity. This is the thing we're worried about here, because it can damage the hair cells in the cochlea. You can see hearing loss associated with that, so that is one thing to avoid. Okay. Other things to note, you can use Cipro and dexamethasone together, but it's very, very expensive as a combination product. Sometimes what we'll actually do to get around that is use the ophthalmic ofloxacin and dexamethasone. And I hear you saying, wait a second, you meant otic, right? And I said, no, actually I meant ophthalmic. Occasionally we will use ophthalmic medications meant for the eye, and we can use that in the ear. That is totally fine. That is totally something that's appropriate. You're not going to cause any problems by going from the eye to the ear. Where you do run into problems if you try to use an otic product in the eye. It's going to cause a ton of irritation. The tonicity is not right. The pH is not right. It's just not right for the eye. So again, you can't go from eye to ear. You can't go from ear to eye. Okay, so it's good to know for things like shortages, or if there is a cost issue at play. These are some ways you can get around that. Up next, we have our ENT antifungals we're going to be talking about here. And so I mentioned ketoconazole before, and this is one you're going to see used fairly commonly, either topically or orally. And so for ENT purposes, you typically see a little bit more oral administration here. Now, there's a lot of problems with this, and so again, better for more systemic sort of fungal indications here because of a lot of the issues it causes, like QTC prolongation, CYP3A4 inhibition, things like that. So not a great drug from that standpoint, but if you do have a more systemic infection that may have arisen from, say an ENT infection originally, this can be useful for those cases there. More often than not, though, we're going to find that things like Nystatin can be used pretty commonly, especially for candidal infections. The benefit of Nystatin is that it has really no appreciable oral absorption there, which is great. So if you had something, patients say had thrush, which is oral candidiasis, basically you can utilize this. The patient can either swish and spit if they can, or swish and swallow. It really makes no difference, and we'll be able to treat that sort of topical, or kind of on the back of the throat sort of infection there. So you can see this if you had a patient who's on an inhaled steroid. This can be useful for treating thrush because of that. We'll talk more about that in the pulmonology section. Patients who are immunosuppressed due to things like chemotherapy or if they have HIV, very good from that standpoint. So again, not absorbed, so no CYP interactions, no systemic interactions you have to worry about. Maybe some stomach upset, but that's pretty much it, because again, it does not get absorbed here. Now let's talk a few about some antivirals. We didn't really cover antivirals in the antimicrobial section here, but let's cover it now, right? And again, you're not going to use all of these for a lot of ENT infections, but I kind of want to talk about them briefly here, and they'll come up later at other points here, but this is kind of our first introduction to them. So whenever you're treating a viral infection, it's important to understand how the viral life cycle kind of occurs here. And so again, typically you're going to find it starts out with something, like the viral cell or the viral particle attaching to the cell. It uncoats itself, reproduces its DNA, individual RNA, and the proteins, and then that will then kind of reassemble itself to bud off and go and infect another cell. There are different ways we can target this, depending on how we're going to be depending on the type of virus it is, depending on the type of infection it is, and these are all valid ways to try to interact and try to inhibit this life cycle to prevent it from going off and infecting other cells here, right? So we'll talk about a few ways we can do that with some of the more common antiviral agents you're going to run into. So first off, we'll mention the herpes virus. Of course, there are two main types of herpes simplex you might run into. Type 1 is mainly going to be seen more for ENT sort of purposes here, where you can see it more causing things like cold sores and affecting the esophagus, things like that. Type 2 is where more relegated to more genital sort of infections there. However, you can find they can kind of commingle in either place, as you might see there. Varicella zoster is frequently causing chickenpox or shingles, and then you have things that are maybe more prevalent in more immunosuppressed sort of individuals, where you can see cytomegalovirus, which can cause like a retinitis, esophagitis, etc. Now, these are guanine analogues. That's kind of the main class of antivirals I want to talk about today. Now, again, as you might imagine, it being a guanine analog, this is going to be something that gets incorporated into the viral DNA. By doing that, you're actually going to find these act as what they call chain terminators, meaning they lack the sugar moiety on the end there that normal nucleotides would have when they get incorporated into DNA. By losing that sugar backbone, basically it causes the DNA to not be able to replicate any further. Nothing else can really be added on to these guanine analogs once they're incorporated into that viral DNA. Once that occurs, then at that point the virus cannot produce any more DNA. It then triggers off basically apoptosis of that particle and prevents replication. So a couple of different varieties here we're going to talk about. Notice some of the relations between these. Some of them are a little more obvious than others. You have things like acyclovir, and then you have valacyclovir. Okay, notice pretty similar in structure, kind of some added stuff here on the end of that tail. Now you have pencyclovir and famcyclovir. Again, pretty similar in structure. And then you have ganciclovir and then valganciclovir. Okay, so keep this in mind as we go forward. We'll talk about why we kind of associate these three pairs together. As I mentioned, it's a guanine analog that doesn't have the sugar moiety added on there that you normally find on a nucleotide. And so because of that, you cannot produce any more DNA unless the virus just can't replicate any further. Now, acyclovir and valacyclovir themselves are normally indicated for things like herpes simplex viruses, varicella zoster. These are the mainstays of therapy for these two here. These are probably the more common ones you're going to run into. As far as bioavailability goes, acyclovir is pretty poor for the most part, around 22%. However, valacyclovir, because you added on this extra, a few extra groups here, you're going to find it is more bioavailable. The reason for that is because it's a prodrug, right? I mentioned prodrugs are inactive as they're given originally, and they get cleaved by the liver. They get broken into the active form, and then that helps to increase the bioavailability. So again, it makes it more active by the time it actually gets converted into acyclovir in the systemic circulation. So kind of a clever way to go about that. Now, big things to note here whenever using acyclovir or valacyclovir, again, causing the same side effects, so they're essentially the same drug once the valacyclovir gets converted into acyclovir. Of course, nausea, vomiting, very common, right? The big things you have to remember is these kidney effects you can see. So you got to maintain good hydration when drinking these, or when taking these, mainly because if you don't have good hydration, you can find that the drug will crystallize out in the renal tubules, and that can actually cause interstitial damage to those cells there, leading to renal insufficiency. Not great, right? Other things you can run into, things like CNS toxicity, okay? So you can see seizures, delirium, tremors related to some of the CNS effects. Again, hard to really square that. It's not really related to the actual mechanism of the drug itself. It just happens. However, the mechanism does inform why you see bone marrow suppression, because it can affect our cells just like it's affecting the virus, right? Now, big things to note here when you have viral infections, really important that you want to try to initiate them as soon as symptom onset occurs, because the earlier you get them on board, the more effective they're going to be at shortening those symptoms there, right? Because again, most of these are not going to cure the infection. It will then just shorten the number of days you have symptoms for. So earlier is better, basically with all the antivirals we're going to talk about today. So especially if you give it in the first 24 hours or so. Penciclovir and famciclovir, again, are going to be very similar to one another, very similar relationship as valacyclovir to acyclovir, used similarly for the same infections here. Notice though that these are going to be more for resistant viral infections, where perhaps you have something that is now resistant to acyclovir. This is where these get used more frequently. Penciclovir actually has such poor bioavailability orally that you can't give it that way. You have to give it IV only. Whereas famciclovir says, hey, I got you, fam. And it says, I'm a prodrug. I'm inactive anyway. Go ahead and give me orally. It's fine. So then it gets put to the liver, gets turned into the active penciclovir, and it has much better bioavailability. So 77% versus just 5%. Okay. And then finally, valganciclovir and ganciclovir. Again, same exact sort of mechanism, same sort of relationship as valacyclovir to acyclovir. You're going to find that here, this gets used more for, say, for instance, patients with transplant, or maybe those that are immunocompromised. Remember, when you transplant an organ into somebody, you have to suppress their immune system, because otherwise you can have what they call graft versus host, where basically the body is trying to expel the foreign tissue you've now put into that patient there. And so they are at big risk for developing viral infections. And so, again, these are going to cause more side effects than the others we've seen, and thus they're going to be more held off unless you have some more of these very severe infections, things like cytomegalovirus. So again, this is the big kind of role for ganciclovir here. Again, you're going to see a lot of blood dyscrasias, see a lot of that neutropenia, thrombocytopenia, and then the CNS toxicity is another very common one. And very frequently, because of the side effects, about a third of patients have to stop IV treatment just because of that. Okay. Another very common, and this one is you're going to run into probably the most common out of the bunch, is going to be oseltamivir or Tamiflu. This is actually going to be targeted against influenza A and B, and this is actually important because we're going to be coming into flu season. Some places are even starting to give out the flu vaccine for this year, and we'll talk more about vaccines later on. But this is going to be a drug that you're going to use very, very commonly, especially like in the October to March timeframe. However, you may find some patients taking it up through May, in some cases, well outside of the normal flu season. It just depends on the season. But basically what this is doing is it will inhibit the influenza virus neuraminidase. And what that does, it will actually help to, will prevent it from producing new these budding progeny here, right? That way the virus cannot replicate itself. It cannot go into infect other cells. Again, this needs to be started as soon as possible. And so very frequently we'll have patients who come in, they're pretty sick. They get flu tested. They're, say, A or B positive. And then they say, oh, well, it's been 72 hours. We may not even give them Tamiflu in those cases there because it has not been shown to decrease the risk of complications. It does not really decrease the time that the patient's symptomatic. It's no good. There are some cases there where we will extend this out and even give it if it's past the 48 hours here. And so if they have really severe disease, if they are less than 2 or say greater than 65, because we know they tend to be more affected by the flu virus, they have chronic conditions like COPD, if they're immunosuppressed, these are the cases where we're going to be using this more frequently. But resistance is becoming much more of a problem over time, mainly because we are overprescribing it. We're giving it for patients who are, again, coming in 3-4 days out from developing symptoms, and we know it's not going to be effective, but the parents still want you to do something, or the people still want you to do something, and so we give it out indiscriminately in some cases, and that's becoming a problem. Now, this is available orally only, and it does require some renal dose adjustments. So you do have to look for that. Just something to keep in mind. And you'll find that the dosing is actually going to be based off of the weight of the patient here. But what's interesting, they have these kind of weight breakdowns. I'm not going to ask you this specifically on the test. I just want you to kind of be familiar with it when you see it out there. Because again, when you go on rotations, it'll be around the time the flu season is kicking off. You're probably going to run into this pretty frequently. And again, this is given twice daily. And once you get above 40 kilograms or so, then you're just given 75. So this is basically going to be just your standard adult dose there. So moving in then into the anti-inflammatory agents you see used pretty frequently in ENT purposes. Here's where I want to talk a lot about the over-the-counter products that you are going to run into most commonly here. Most of these are going to be available over-the-counter, and this is important to know because patients are going to be self-treating themselves pretty often. And so because of that, I want you to be aware of them because you need to ask questions. You need to know what your patients are taking or not taking, and then what to recommend potentially based on what they're doing. So starting off with our anti-inflammatories is going to be the salicylate category, which mainly just includes aspirin, right? Aspirin is oftentimes abbreviated ASA. If you ever see that, that basically stands for acetyl salicylic acid. Most people just call it aspirin, right? Now, again, this is basically going to be working by non-selective inhibition of cyclooxygenase 1 and 2. Basically what this means is that normally cyclooxygenase will produce a lot of inflammatory mediators like prostaglandins and prostacyclins, etc. By interrupting that, by preventing cyclooxygenase from working, you prevent the production of those inflammatory mediators, and thus you decrease inflammation. Very good at doing so. In fact, this falls into that category of non-steroidal anti-inflammatory drug, and this works just the same as you would see with like ibuprofen or naproxen or any of those. Okay. Note here, this is an irreversible inhibitor. We've mentioned this before, but this is again why you see baby doses being given for prevention of myocardial disease or MIs and things like that, mainly due to its platelet effects. We'll talk more about this in the cardio section later on, but kind of just keep that in the back of your mind. All the other ones we're going to talk about today are going to be reversible inhibitors of cyclooxygenase. Now, it's important to understand the dosing that we're giving here. If you're just using it for antiplatelet effects, you can get away with pretty small doses like 81 milligrams a day, and that's totally fine, right? So between 81 to 325 milligrams a day, the antiplatelet effects. It's important to know, though, that it's really easy to overdo it with salicylate, and so, going between, say, 650 milligrams to 1 gram, you get good antipyretic effects, so it's going to help to lower fever, it's going to help with pain, it's all good from that standpoint. That's where you're going to get the majority of your benefit out of this. However, things you want to look for, things like bleeding, especially GI bleeding, hypersensitivity could be a risk. Those are the things you want to note. However, when you start to get above that, and say you have patients who are taking more than they're supposed to throughout the day, or maybe they're stacking up, say, aspirin they're taking for the flu that they have, and they're also taking BC powders for headaches or something like that that also contains aspirin. This is where you run into, again, more anti-inflammatory effects, but also this is where you start to see the tinnitus that can develop there, and then eventually get into severe toxicity. And I probably mentioned my scale for how I worry about certain overdoses and things like that. Whether I worry about it in terms of sphincter tone of it being, say, a 1, which tone's not very high, versus a 10. This can be like a 7 or an 8. Like salicylism, especially chronic ingestion, can be really difficult to manage. I'll talk more about this when we get into a tox section towards the very end of your pharmacy curriculum. But again, this can be one of those scary ones. Now, contraindications to taking aspirin would be if you already have a bleeding disorder, because this is going to worsen that, mainly by inhibiting the activity of platelets. And then also, you may not want to use this in pregnancy very frequently. We'll talk more about this in the OB-GYN section, but just use this pretty cautiously. And then the other big thing you have to watch out for is what they call Ray's syndrome. This is where basically if you give this to children who have had a recent viral illness, mainly influenza, chickenpox, etc., if you give this to them in the post-viral period, they can develop what they call Ray's syndrome. This is a potentially fatal complication of giving aspirin. You typically see this in kids less than 15 years of age, and if not treated aggressively, can have a mortality of around 50%. Basically what happens is you're going to find that it has this kind of progressive CNS damage that can lead to an encephalopathy. You're also going to find a lot of liver damage that happens here, so they can develop this kind of fatty liver. They have things like mitochondrial dysfunction, etc. And so the problem, though, is that the symptoms look very frequently like an upper respiratory tract infection. And so I'll show you what this looks like in just a moment. But there's been a lot of campaigns out there that have been trying to eliminate utilization of aspirin in this young patient population. And so in general, you probably want to avoid most aspirin in kids less than 16 years of age, because again, you never know when they're going to get a virus and when they may be at risk for this. There are notable exceptions. There are plenty of cases where it's totally appropriate to use aspirin in pediatrics, but for the most run-of-the-mill stuff, just use something else. We have plenty of other agents here. Okay. One other big thing to note here is that Pepto-Bismol is bismuth subsalicylate. So there is salicylates in there, right? So also you want to avoid Pepto-Bismol or anything that contains salicylates in that patient population, less than 16. So 5 stages you're going to run into. So they can develop rash, vomiting, high fever, lethargy. Guess what this looks a lot like? It looks just like a viral illness. And so a lot of times this can be missed. They can then develop encephalitis, hyperventilation, fatty liver, and eventually can develop into cerebral edema, and then eventually further hepatic dysfunction, and eventually seizures and death. So again, this is one of the things where if you don't catch it early and it's kind of sitting there just simmering away, that's where you can lose a lot of time and where patients may be more likely to die. So again, how would you educate patients on taking this? Again, take it if they have a fever. A lot of people get fever phobic, and meaning that, especially if they're going to come in to see the healthcare provider, they don't want to take anything for their fever because they feel like if they don't have a fever when they see you, then you're going to think they're lying to them, and that they're lying to you, and that they never had a fever to begin with. That's just silly, but people just don't know about that. So make sure they're taking it. They have an actual fever. Make sure that they're drinking plenty of fluids anyway, because then again, most people get dehydrated when they're sick like that, and then typically don't take it for more than say 10 days if things are not getting better, because then they probably need to follow up on that. Make sure, really big deal, that one, they don't take this with any other NSAIDs, because these have the same exact action. So because it could be appropriate to take Tylenol with ibuprofen, but do not take aspirin with other NSAIDs. Okay, and then if you're taking any sort of blood thinners, this is going to worsen that. So you got to be really careful and make sure that they are consulting with their cardiology or person or whoever before they decide to take aspirin along with any of their other blood thinners. Up next, we have ibuprofen. Again, super common over-the-counter non-steroidal drug you're going to run into. Again, same activity as aspirin. It's going to have an anti-inflammatory effect, analgesic effect, antipyretic effect, very good from all of that standpoint. And again, this one, the one thing that delineates it in terms of activity from aspirin is going to be the reversibility of its activity on cyclooxygenase, meaning that once the drug is out of the system, once it gets eliminated through the liver, basically the antiplatelet effect is gone, the anti-inflammatory effect is gone, basically you return back to normal. So again, what are you going to use this for? Mainly for fever, mild to moderate pain. Obviously, the dose is really going to be dependent on the severity of inflammation, where you may find some patients taking 800 milligrams 3-4 times a day for like rheumatoid conditions, whereas for something more minor, maybe say taking 200 to 400 milligrams 3 times a day. Just really depends on what you're looking for in terms of activity. Biggest things to watch out for, though, are going to be the effects on the gastrointestinal tract, We'll cover this in much more depth when we get to the GI section later on. But basically, the GI mucosa that is it produces a barrier that prevents your stomach acid from eating through and eating up your stomach, right? So all the stomach acid you produce would cause a hole in the stomach to appear if you did not have this nice mucousy sort of bicarbonate laden sort of neutralizing barrier. Well, a lot of the stimulation for that occurs through prostaglandin synthesis, and one of the things you'll find that NSAIDs do is they inhibit prostaglandin synthesis. So because of that, you can actually cause this barrier to degrade and cause the stomach acid to actually eat through the stomach, causing an ulcer. That can lead to perforation, that can lead to bleeding, can lead to death potentially. And in fact, NSAIDs are the number one cause for gastric ulcers in the U.S. because of the fact that they are taken sort of with impunity, and people don't realize when they're taking this stuff chronically that can actually develop. Okay. Other things you're going to run into are going to be issues of edema and fluid retention, and this can actually raise blood pressure. A lot of the reasons for that is, and we'll get into this more when we talk about this in terms of renal physiology, but I'm sure you've covered some of this in physio previously, so I'm going to kind of do a very crude drawing to kind of make sense of this. If you remember back to your renal physiology, if you remember the glomerulus, we'll say this is the glomerulus here, and this is the renal tubule. It's going to then filter everything into. Normally, you're going to have both an afferent arteriole, so again, blood's coming in this direction, and then you have an efferent arteriole, things going out back to the rest of the body, right? So blood's coming out this way. Well, how you maintain that glomerular filtration rate is very dependent on the amount of fluid coming in and the amount of fluid going out. Typically what you find is that prostaglandins will normally cause vasodilation here of the afferent arterioles. That should be an arrow pointing down that way. This allows more fluid to come in and allows for GFR to stay high, right? Well, if you have an NSAID come in here, it's going to then get rid of these prostaglandins, causing vasodilatory sort of effects, and this will then narrow that afferent arteriole, and that can actually raise blood pressure, because the kidneys sense, hey, there's not enough volume being filtered. Let's try to increase renin, angiotensin 2, and all that good fun stuff. And also you can cause an acute decrease in kidney function because you're decreasing the amount of fluid coming into the glomerulus. And so for most healthy patients, this isn't a big deal. They don't really require that much prostaglandin effect to really maintain good GFR. For patients, though, that have maybe some long-standing mild kidney disease, they really need that prostaglandin effect around. So by getting rid of that, you're going to find that can cause an acute kidney injury. Okay, that's why I say things like NSAIDs, like ibuprofen, are nephrotoxic. This is the reason why. Is because for patients who have maybe mild to moderate kidney disease, or even more severe kidney disease, they're really dependent on the prostaglandins. Now, again, we'll talk much more about this later on. We get to respective sections, but just know this is the reason why they say NSAIDs can be nephrotoxic. Okay. Now, again, if you're just now joining, again, this is not a uterus with the fallopian tubes. This is actually a glomerulus. Just FYI. Okay. So, again, things you're going to notice here, they tend to interact poorly with blood pressure medications. And just for the reasons that I mentioned, is mainly because you're going to find that by having its effect on the glomerulus, you're going to have the kidney sensing there's not enough pressure, there's not enough volume being filtered, and so that's going to cause increased release of things like aldosterone, angiotensin 2, renin, all that good stuff. And that will then cause things like ACE inhibitors, which block the activity of angiotensin 2, or inhibit the activity. It's going to make it work less effectively. We'll talk much more about this in the cardio section coming up, so just kind of keep that in the back of your mind. But this can interact with all kinds of drugs. Lithium, it can interact with methotrexate, it can cause more bleeding. So there's a ton of drug interactions here you have to watch out for. And again, this is available over the counter. You can go to Costco, spend $10 and get a 55-gallon drum full of this stuff. So you got to be really careful of this stuff. Got to ask the right questions, because you can get yourself into some major trouble if you don't ask. Okay. Other things to know here, right? So obviously any allergies, you don't want to take the drug. This can actually exacerbate asthma in some patients there. When we get to the pulmonology section and talk about asthma, I'll talk about exactly why that is. But just know that NSAIDs can induce asthma in certain patients. We don't want to use this in any kids less than 6 months of age. The reason for that is actually if you have some kids who have an undiagnosed patent ductus arteriosus and undiagnosed cardiac disease or congenital heart disease, they may actually need this open, and so NSAIDs can actually close it. And we'll talk much more about that in the pediatric section. I know there's a lot of stuff. I'm just trying to keep you guys interested, so that way you stick with the class, you don't just drop it in the middle of the semester. I'm just kidding. You can't drop it. You're stuck with me. But I'm trying, again, these are things we're going to talk about when we get to the respective sections later on. But other things, if they have a previous history of stomach ulcers or perforation, you may want to avoid this. If they have renal dysfunction, you probably want to avoid this as well. We have other drugs you can use instead. So, as again, we'll talk more about other NSAIDs when we get into talking about pain specifically. But just so you know, in terms of oral agents available over the counter, naproxen is going to be another one. The nice benefit with naproxen is a longer half-life, so it only requires, say, 1 to 2 times daily dosing. Ibuprofen usually requires 3 to 4 times daily, so it could be a bit of a compliance issue for some patients. Up next, with tried and true standard Tylenol, acetaminophen. If you ever were curious why Tylenol gets abbreviated as APAP, that is actually because of the chemical name itself. If you notice, acetyl para amino phenol, that has APAP right there, right? As if anyone was ever curious as to why the name is Tylenol, it actually comes from the chemical name as well, where you have TYL, and you have the enol over here. Again, these are things you could use to impress potential mates. These are things you can use at dinner parties, and you will be the life of the party. I know. People are so jealous of my drug facts, they just don't even invite me to the parties anymore. So, there you go. Anywho, the mechanism here is not quite fully elucidated. We don't really know why Tylenol works so well. Some people postulate it works on sort of a COX-3 enzyme, but who's to say? Anyway, the big difference here between the actions of Tylenol versus something like your ibuprofens is that this does provide analgesic activity, it provides antipyretic activity, no anti-inflammatory activity. Tylenol's kind of working more up in the CNS to do with pain and to do with fever. It doesn't really do anything for the inflammation at the site where it's occurring, as something like an ibuprofen would. So again, more limited in activity. However, this is a really good drug to cycle on and off with ibuprofen. Some patients, they'll come in and you'll say, hey, go ahead and cycle Tylenol and ibuprofen. Most of the time, these are both going to be dosed every 6 hours, and so you can basically have them piggyback off of one another to where, say, at 9 o'clock in the morning, they take ibuprofen. At 12 p.m., they go ahead and take acetaminophen. At 3 p.m., they take ibuprofen, and so on and so forth. The nice thing about that is it provides good 24-hour sort of coverage there if you're treating pain or if you're treating fever in those cases. Big things to note with Tylenol is that hepatic toxicity is the big thing we worry about. Namely, if you're taking, say, more than 4 grams in 24 hours, that's not to say if you took 4 grams in a 24-hour period, your liver automatically dies, right? But this is a chronic thing. So if you have patients who maybe have hepatic disease beforehand, they're more at risk. Or if you're chronically taking 4 grams or more every single day, that's where you really run into some big problems there, okay? Other than that, there's no bleeding risk. There's no kidney issues. It really lacks a lot of the problems that you saw with the NSAIDs, but the liver thing is the one you have to worry about, especially with the high doses. And again, greater than 4 grams in 24 hours for several days is a problem. Other things you can note here as well, with chronic alcohol ingestions, you can find that Tylenol can actually predispose a patient to more liver damage due to alcohol and vice versa. That's one thing to note. And then other than that, no real contraindications. Very, very safe to receive sort of drug. Okay, moving on. Next, we're going to have some systemic antihistamines. So histamine is a very common substance that gets released from immune cells, and it's responsible for causing a lot of the triple response you see with an allergic reaction, namely that redness caused by vasodilation, the wheal caused by edema, usually due to the capillaries becoming dilated and more leaky, causing more permeability. And then the flare, that's mainly going to be due to some vasodilation, causing redness around the area of primary insoles. Imagine getting like a bee sting or something like that. You see that redness, the wheal, and then the flare that happens around it. Now, what you're going to notice is there's 2 main types of histamine receptors. There's actually a third, but clinically we're not going to talk about that. There's H1 and then H2. The primary thing we're going to focus on for this purpose here for ENT is H1. H2 is primarily a gastrointestinal sort of thing. We'll talk about H2 in depth when we get into the GI section later on. But you can see here the histamine 1 receptors are pretty widespread in terms of where they're at in the body. And when you interact with them, you're going to find a lot of very serious effects. And this is really important, especially when you talk about things like anaphylaxis and allergic reactions. And again, we're going to talk about that extensively in the palm section later on. But this is your first introduction to it. So what do you see here? You see interactions with things like the blood vessels, right? So the vasculature can cause decrease in total peripheral resistance. It can lead to things like increased permeability here. So what do you see when you have a patient with anaphylaxis? You see hypotension develop. You can see increase in heart rate. You're going to see that the bronchial smooth muscle tends to contract, can impair airflow, right? You're going to find things that the gastric smooth muscle tends to contract, right? So all these things are really typical of H1 receptor activation here. And so these are very common in a lot of allergic reactions, whether it's due to pet dander, seasonal allergies, bee stings, whatever the case may be. And so we're going to find that these are very useful drugs if we can inhibit the activities of H1 or histamine at the H1 receptor. So, as I mentioned, these are a lot of the effects you're going to see. A lot of vasodilation. You can see a lot of increased mucus secretion here. That's why when you have allergies, your nose gets nice and stuffy, and you're having a lot of mucus being produced, or a lot of snot. I mean, you may think it's funny, but it's not. Bronchial secretions, GI secretions, all these things. Smooth muscle tone goes up. And so you're going to find that this is a really powerful component of the allergic system, that if we can inhibit this, it's going to be able to have pretty widespread effects here. So antihistamines can have very strong effects on the body depending on if the patient's having some sort of allergic process. As mentioned, H2 receptors we're going to talk much more about in terms of its effects in the GI tract, but you can see here activating causes a lot of gastric acid secretion, mucus secretion, things like that. We'll talk much more about this later on, so kind of keep that in the back of your mind. So what are the effects of an H1 receptor antagonist? Okay, so some of the peripheral effects you're going to find is it can block smooth muscle contraction. So that's not only in the GI tract, but more importantly in the bronchial smooth muscle. It helps to allow us to breathe a little better because that smooth muscle is more relaxed, the airways are more open. You're going to find you have blocking of that vasodilation. There's less secretions, there's less edema, less itching associated with that, right? So these are all very positive things if a patient's having a more sort of systemic sort of allergic reaction to something. Some CNS effects, so these are really important because these are a lot of the side effects. In some cases, may actually be beneficial to the patient, and a lot of times they may not be. So what you're going to find is that the sedation is the major side effect of the H1 antagonist. Some of this is related just to H1 blockade itself, but you also find that a lot of these actually will inhibit muscarinic acetylcholine receptors. So these have an anti-muscarinic sort of effect as well. And so that can lead to a lot of sedation. You can actually find that if you mix this with other CNS depressants like alcohol, this can be a big problem, causing increased sedation. However, you may use it for this purpose here, right? So people have sold doxylamine, which is an H1 antagonist, as a sleep aid, right? That's Unisom. So there's some cases where this may actually be beneficial. Things you may see, especially in children, are going to be this paradoxical reaction where they can actually get very restless and excited, especially at higher doses. These are cases here where you expect the kid to get sleepy off a dose of Benadryl, but they end up going absolutely ballistic. They're bouncing off the walls, they're fighting people. They can become very erratic when they're on these paradoxical reactions there. So that's one thing to note. And then oftentimes we will find this is a common source for adolescent overdoses, mainly because they're trying to get high, and it's very easy to get access to a lot of H1 antagonists. Most over-the-counter section and the cough and cold section is nothing but histamine receptor antagonists. So how do you get around this? Like, how do you get around a lot of these CNS effects that can be negative in some cases? If I'm a truck driver and I need to be on the road for several hours out of the day, I don't want to be sleepy because I have seasonal allergies and I took a Benadryl. So because of that, we actually came up with our second generation agents. And so this actually goes back to that, the idea of charge and it causing molecules to move or not move across a membrane here. What you find with the second generation agents is they all have a permanent positive charge on them. They actually have a quaternary amine structure, where basically they have, and again, hopefully none of you remember enough chemistry to prove me wrong if I am, but basically you have a nitrogen in the middle of a group and you have 4 attachments to it, and then this causes it to have a permanent positive charge, and that prevents it from actually crossing the blood-brain barrier, meaning that if it can't cross into the blood-brain barrier, it can't have its central sedating sort of effects there, right? So that's kind of the big benefit of the second generation drugs. Other things you're going to find with the first generation agents, again, these are the ones that do cross into the blood-brain barrier. They can have good antiemetic actions, especially if it's due to things like motion sickness. They have good anti-secretory actions because they're anti-muscarinic, so they'll dry you out a lot better than, say, a second generation one. And in some cases, you may find some anti-serotonergic action, although clinically this isn't that important. As I mentioned, good antimuscarinic actions here. This is mainly due to it blocking muscarinic acetylcholine receptors on the chemoreceptor trigger zone. As an example, promethazine or Phenergan has probably the strongest antimuscarinic actions here, and so this is why it's so good, especially for things like motion sickness. It'll also dry you out the most because it has all this antimuscarinic activity there, right? So what are the indications that we would end up using H1 receptor antagonists? Well, if we have things like allergic reactions, insect bites, drug hypersensitivities, anything like that. Motion sickness, again, this is going to be the first generation agents only, right? Because, again, the second generation are not going to cross into the blood-brain barrier. We can use for OTC sleep remedies. Again, this is only for the first generation. And then this is also going to be an adjuvant role in anaphylaxis. Okay, so again, if you think about your anaphylaxis medications, usually epinephrine is kind of the first one you give, but also antihistamine is going to be the other major drug you give along with that, and a steroid. So what are some of the adverse effects you're going to see with your H1 receptor antagonists? Mainly you're going to see sedation being one of the biggest things there. Again, some people, even 25 milligrams of Benadryl can just totally knock them for a loop, right? And 25 is kind of the starting dose for most adult patients. Maybe some GI disturbances and a lot of antimuscarinic effects. And again, this is mainly the first generation drugs we're talking about here. We can see dry mouth, urinary retention, blurred vision. Remember the antimuscarinic mnemonic we came up with last semester, right? We talked about dry as a bone, hot as a match, you're blind as a bat, mad as a hatter, red as a beet. These are all things you're going to see from the antimuscarinic activities, and these are the most common drugs that are going to cause that because, again, they're available over the counter for the most part, so you're going to see it very commonly. In some cases, you may have some hypersensitivity. This is if you're using topical antihistamines like a topical Benadryl, but fairly rare for the most part. So this table is really handy to go back to when you're studying the different agents that fall into this category here. Because again, remember on testing, for testing purposes, I can ask you a question, say which one of these drugs is most likely to cause sedation for a patient. Or I'll come up with a situation where you have a PA student who is having seasonal allergies, but they really need to stay up and study all night for their pharm exam the next morning. Which one of these agents would be most likely to cause sedation, right? And so I would say, give you a first generation agent, I give you a second generation, then say two other distractors. So your job though is to be able to recognize, okay, I know cetirizine is a second generation drug. I know that's very likely to cause sedation. I know hydroxyzine is a first generation. It's very likely to cause sedation, right? These are things I want you to know here. The duration of action I'm not so concerned about, but certainly kind of memorizing the general themes of this table more so than just memorizing that, okay, well, fexofenadine is a very low for sedative effects versus cetirizine is low, right? Again, the general themes I want you to know. So in this case here, first generation agents, again, they can cross the blood-brain barrier fairly easy. You're going to have things like chlorpheniramine, dimenhydrinate, which is Dramamine. You're going to have diphenhydramine, hydroxyzine. Note, this is not hydralazine. Hydralazine is an antihypertensive we'll talk about later on in cardiology. We have meclizine and then promethazine. These are the main ones you're going to run into in terms of your agents that are in the first generation antihistamine category. What do you notice about their effects in terms of sedation, antiemetic, anticholinergic? Mostly medium to high for the majority of these, right? So again, any of these are relatively interchangeable. A lot of it just depends on how they're available to give. As an example, a lot of these are available orally to be given either as, say a tablet or a liquid like diphenhydramine, hydroxyzine. Some of these are only available over the counter, or are available over the counter, things like chlorpheniramine, dimenhydrinate, diphenhydramine. What if you had a patient who's really nauseous and couldn't take anything orally? Well, like promethazine comes either intravenously, or you could actually have a rectal suppository for that, right? So these are things you'll learn about and kind of get a feel for. But again, if I were to ask you, hey, which one of these routes would be most appropriate for someone who has having nausea, the rectal route may be most appropriate, right, as the case may be. Those are your first generation agents. Second gen are going to have that permanent positive charge on the molecule, which prevents it from getting into the blood, across the blood-brain barrier. So again, notice here, no sedative effects, very low anticholinergic effects, no antiemetic effects, right? These are the things to know here. You have cetirizine, which is Zyrtec. You have fexofenadine, Allegra, and then loratadine. You're starting to find that more drug companies are offering enantiomers of these. So there's like a levocetirizine, and there's like a des loratadine. They're going to have the same exact activity as these. And again, most of the time they're just doing it for a new patent extension, right? There's one intranasal antihistamine, which is azelastine. Again, not used too commonly, but the benefit of an intranasal antihistamine is only working locally right there in the nose. You will not see any other systemic side effects. So as I mentioned, azelastine normally comes as a nasal spray available over the counter, good for just nasal symptoms, right? So if you're having allergic rhinitis, vasomotor rhinitis, very good for that. However, things to note whenever you have intranasal medications here is that bitter taste can happen. That's mainly due to medication going out the back of the throat and hitting the tongue. Nosebleeds are also going to be another common thing you may see with these. Again, as it has a drying effect locally on that nasal mucosa, that can lead to cracking and can lead to bleeding potentially. So that's one thing I want you to know with that. Now, as far as education goes, and this can apply really to any of the nasal sprays that we'll talk about, and we'll talk about a few more coming up here. Biggest thing to do first, make sure you blow the nose and clear the nostrils. Why do we do that? Well, if they're full up of boogers and snot, you don't have a lot of good contact of the drug with the nasal mucosa, so tell them to blow out their nose first, right? Tilt their head down, that way they're not getting a ton of it all the way back and hitting the back of the throat eventually. And basically, what you're going to do is have them angle the spray away from the septum, so that way you don't want to have to worry about any kind of septum trauma the way they're using it there. Typically, you're going to use the right hand for the left nostril and vice versa there. So again, I was kind of using bad technique at first, but use the right hand for the left nostril and vice versa. And then don't tilt the head back, because again, that just puts more medication in the throat. Sometimes that'll trigger the gag reflex for some patients and cause them to throw up, so don't do that. Have them clean the tip of the bottle off to make sure that it doesn't retain any sort of infectious particles. Obviously, don't want to share this with your buddies. No matter how close of a BFF you might have, I probably would avoid sharing that, just in case you like to share your cooties with one another. And typically, you would want to avoid using this at the same time as other nasal sprays. You at least want to spread it out, at least say 5-10 minutes or so, to make sure there's no cross-contamination there. You let one drug work and then apply the next one if need to. Okay. If they start to develop nosebleeds, again, this would be one thing you'd probably want to just discontinue use and have them follow up. Obviously, if it's not stopping or if it's ever getting worse, then yes, that's certainly something you wanted to follow up on. So next up, kind of following the same line as the anti-inflammatories, we have the corticosteroids. As mentioned, these are basically steroids you might administer. Now, again, these are very, very powerful in terms of causing decreased inflammation. The reason why they're so powerful is that they actually get down to the site of the nucleus itself, and they change the transcription of these inflammatory cytokines. Same thing to go along with that, we mentioned that things like ibuprofen work on cyclooxygenase to prevent the actual production of inflammatory cytokines. That works a lot faster than something like a corticosteroid. Corticosteroids have to actually get down to the site of the nucleus and they change the protein transcription. They do nothing about proteins that are already made, leading to inflammation. So these take longer to work, but they are overall much more powerful than any of the other anti-inflammatories that we have. They also lead to a lot more side effects, as we're going to see there. So a lot of nasal corticosteroids. Again, what's the benefit of just using a nasal corticosteroid? They don't have a lot of systemic actions. We'll see some of those systemic side effects in just a moment here. But the nice thing here as well, we actually have some of these that are available over the counter now, which was not something we had for a good long time there. So that's actually a big benefit to some patients. They don't have to get a script just to use these. So you have things like beclomethasone, you have budesonide, flunisolide, fluticasone, mometasone, triamcinolone. There's a lot of them here. And again, most of these have a nasal preparation. They also have an inhaled preparation for asthma. So don't get them mixed up. The very common medication error is for Flonase to be confused for Flovent. Flovent is the inhaled form. Flonase is the nasal form. Seems like the naming would be clear enough. However, if you don't relabel, you just see fluticasone, you may get the two mixed up there. So that's one thing I want you to know, is that these formulations do have their counterparts for the inhaled route, and don't mix them up. Okay. Again, when would you be using these? Mostly for allergic rhinitis, for vasomotor rhinitis. These do not do anything for systemic symptoms of allergies. They only work for that nasal sort of effects there. And again, very similar sort of effects as you would see with the other nasal sprays like epistaxis, unpleasant taste. Septum perforation is a very rare thing, but it would happen more with chronic use. One thing we'll learn about glucocorticoids is they actually can impair wound healing, and so this can happen locally. You may see a septum perforation, but that's a very rare thing. It would be with very chronic sort of use. The other thing to note with the inhale or the intranasal corticosteroids is that they're going to take, say, days to weeks before they really kick in and work. when they do start working, they're very good at what they do. The problem is the patient needs to continue using it consistently, because if they stop taking it, guess what? You lose that effect at the nucleus, thus the inflammation goes right back to where it was before. So that's one thing to note with those. But those are good for chronic use because they don't have any systemic sort of effects. Okay. Now, what are a couple of agents that we can use, say, systemically, either orally or parenterally? They're good for short courses to try to decrease a lot of inflammation associated with, say, an acute infection or something. A couple agents we have, things like dexamethasone, right? This is basically a synthetic corticosteroid that we have here that is good for all sorts of reactions, asthma, COPD, drug hypersensitivities, and really anything where you need to decrease inflammation. This is what's going to be used here, right? This is one of the ones. This one's also nice because it's available parenterally. You can give it intramuscularly, IV, also available orally, which is good. So what are the effects you're going to find with that? Because it is a corticosteroid, you're going to find that it has a lot of effects, kind of ancillary side effects you're going to find. And because we're giving this systemically, there's a lot of systemic side effects. So what are those things? Some of them are going to be the mineralocorticoid effects, okay? Meaning mineral, meaning salt, meaning they help balance salt and water balance. So what you tend to find is that by having effects similar to something like aldosterone, you tend to have more fluid retention, which can worsen hypertension for some patients, or it can worsen CHF. If you have someone with poor left ventricular function, they're holding on to more fluids, that can cause them to go into an exacerbation of their CHF, right? Not great. You can also see glucose intolerance. What do steroids do in the body when you're stressed out? Well, that's your fight or flight response. That's increasing blood glucose to deal with the stress. So glucose intolerance is going to be worse, especially patients with diabetes. Right, you give this to someone, you're going to see the sugars go up. They may need to adjust their insulin or things like that to deal with that. Other problems you're going to see include things like hirsutism. You can see potassium losses, sodium retention, tendon rupture. Like a lot of that has to do with that wound healing we talked about there. You can worsen intraocular pressure. You can have decreased resistance to infections. Corticosteroids, because they're anti-inflammatory, they're thus immunosuppressive. So you can actually weaken the immune system. We actually give dexamethasone to patients with certain types of leukemia to prevent their white cells from replicating. Okay. You may sit there and you say, wow, these are terrible effects. Why would we ever use these drugs here? Because they're really good at dealing with the inflammation. The thing is you have to consider is the duration of therapy, right? Oftentimes for these sort of minor ENT sort of afflictions, you can use them for, say, 5 days or so. 2 or 3 days or so. These are not chronic effects, right? These are going to be things that is a temporary solution to a temporary problem. The big problem you run into is when patients have a more long-standing, more long-term sort of issue, like rheumatoid arthritis, right? Where you're giving it to them every single day. This is where you run into more of these issues here, okay? So in the short term, you may certainly see their hypertension get worse, their glucose go up. However, some of these other effects are going to be much more long-term. You may not need to worry about them quite so much if they're only on it, say, for 5 days. Okay. Other things you're going to find, this can interact with things like diuretics to worsen hypokalemia. You may find that through certain CYP interactions, things like macrolides can decrease the clearance, so you see more of an effect there. Obviously, I mentioned things like, the effects on anti-diabetic medications. You can see issues with digoxin due to hypokalemia. There's a lot of different effects you can see with this, mainly due to the direct either mineralocorticoid or the glucocorticoid effects of dexamethasone. But the nice thing here is if you learn these effects just for dexamethasone, guess what? They apply to all the other systemic corticosteroids we're going to talk about as well. Right. Contraindication you want to consider if they have a systemic fungal infection, that would be bad because this would actually impair us from being able to fight that off, which suppress our immune system. And then the other big thing you want you to know is that, yes, you look out for things like viral infections, bacterial infections, but this is the big thing here. If they're on it for greater than 1 week, you need to not discontinue the drug abruptly. The reason for that is because when you supply exogenous or external corticosteroids to the body, the adrenal glands pick up that hint and they say, well, there's enough steroid around, I don't have to do anything anymore. So they go on vacation and they tend to atrophy. That starts to happen around more than a week or so of therapy. So what happens is if you have patients on it long term and then they all of a sudden stop taking it cold turkey, guess what? The adrenal glands take time before they'll actually kind of kick back into producing things like cortisol, right? So because of that, you need to taper off of the dose of dexamethasone over the course of, depending on, maybe over a week or maybe over 2 weeks. Just depends on the chronicity of use beforehand. If it's less than a week, if it's 5 days of therapy, less than 7 days, you don't have to worry about it. The adrenal glands have not really had time to shut off, and so you can discontinue abruptly, no problem, right? So just because someone goes on steroids does not mean you have to taper it, But if they're on it for more than a week, then yes, I certainly would recommend tapering. Very similar to dexamethasone is prednisone and prednisolone. Actually, prednisone is a tablet form. Prednisolone is a liquid form we would give to children. However, prednisone gets converted into prednisolone in the body. So this is actually kind of a prodrug almost. Same exact actions as dexamethasone. Again, the dosing is a little different. The potencies can change between corticosteroid to corticosteroid. And again, depending on how much of an anti-inflammatory action you need here, the doses change, right? So it could be between 5, maybe up to 60 milligrams per day. Just depends on how severe of a reaction you're treating. Depends on the size of the patient, etc. And again, all the same sort of side effects you're going to see, just like we saw with dexamethasone. So no point in belaboring them a second time. Again, relatively same contraindications here. In terms of patient education, remember not to discontinue abruptly if it's been more than 1 week, and watch for those reactions there, watch for infections, especially if they're immunocompromised. Next, we have our decongestants. So what are going to be some things that can help us to kind of relieve congestion that we're feeling there? Here are going to be some intranasal drugs we have that can treat nasal stuffiness. And so the first one we have here is oxymetazoline, otherwise known as Aspirin. Aspirin is a common brand name for that. This one is basically going to work on alpha receptors, namely alpha-2 receptors, and it can actually cause vasoconstriction, especially when working very locally or in the nasal mucosa. It has some crossover and can actually work on alpha-1 receptors. If you remember, alpha-1 causes vasoconstriction. So by causing that vasoconstriction, you decrease a lot of that, the leakiness of those capillaries. Thus, you have less edema. Thus, that opens up and allows for better airflow and deals with that congestion. One thing you have to note, and I'm sure Professor Q has already mentioned this, is that there is a 3 to 5 day max you want to use this for. Okay. The reason why this is because your nose gets very used to having that effect around. And so if you're on it for more than that, you can have what they call a rebound rhinitis. It's a very severe form. This is called rhinitis medicamentosa, where basically the rebound stuffiness is way worse than you would see than if you had just never taken the drug in the first place. And actually some people can become quote unquote hooked on Aspirin because they've been taking it so long and they can't stop because that stuffiness is so bad, they feel so miserable that they just have to keep taking the drug. You could deal with that by kind of slowly tapering off the drug over time. But again, if you just don't use it more than 3 to 5 days, then you don't have to worry about it in the first place. Okay. Other things you can see with this is because it causes vasoconstriction, this can cause worsened hypertension, so you do want to watch out for that and make sure to monitor if patients do have existing hypertension. Other things you can find here, it can actually interact with things like monoamine oxidase inhibitors and other antidepressants. I would be careful with that. Less likely to occur, mainly because of the fact that it is working more locally in the nose. However, you do see some of those systemic effects, right? The nasal mucosa is very vascular, so you can see some absorption, but it is relatively limited here, right? Again, same directions for use as you would see with other nasal sprays, so I'm not going to belabor that point. We've already covered that. Now, that was a nasally administered medication there with oxymetazoline. What can we use systemically, right? Remember, if you give it systemically, you're more likely to see more systemic symptoms. So now we have pseudoephedrine or Sudafed. Now, pseudoephedrine is going to be considered an oral decongestant. You take it orally, it gets absorbed. And this, again, it works as an alpha agonist. So it's going to constrict those blood vessels in the nasal mucosa and cause it to have less leakiness. You're going to see less edema and relieve a lot of that congestion. So this can also help with some eustachian tube dysfunction as well due to viral infections. That's kind of a minor use, but the nasal congestion is the biggest thing. Now, as I mentioned, you can see more systemic effects from this because it is oral. So think about things like tachycardia. You can worsen, patients who have a history of angina can be worsened by this. You can worsen hypertension. Some patients have had TIAs or strokes related to this. So headache can be seen. So be very, very aware of that. It's going to be sort of antagonistic to a lot of your antihypertensive medications. Now, the big thing with pseudoephedrine is that it was is used illegally to produce methamphetamine. It's actually a precursor to methamphetamine. So a couple of things to note with that. One is that if a patient is taking pseudoephedrine, they can pop positive. It's a false positive for amphetamines on a urine drug screen. So one thing to note for patients, right? Usually if you do a urine drug screen and it tests positive, they will do a follow-up check to see what it actually is. They'll usually do like a gas chromatograph or a mass spectrometry to see what it really is. But just know that it's a false positive. Other things you might see is that in order to curtail the production of methamphetamines, the government decided to go ahead and lock it behind the counter. So it doesn't require a prescription to get, but you're limited in how much you can buy. You have to show an ID in order to get it. You kind of feel like a criminal when you're going to buy the stuff. However, that was the purpose. Whether it really works or not, who's to say? But they keep a much tighter leash on it in terms of how much you can actually pick up per month. So instead, so what did the manufacturer of Sudafed do instead in order to make sure people still bought the product? Well, they went ahead and they had something, they basically call it Sudafed PE, which stands for phenylephrine. Phenylephrine itself is also a alpha agonist, but when you give it orally, the drug doesn't work that well. It actually is very kind of a crummy substitute for pseudoephedrine. Pseudoephedrine is really good, orally bioavailable, decongestion. Phenylephrine, while good in some cases, like for IV usage, it's terrible oral. So what I always tell patients is don't even bother that PE stuff. If you need to have a real nasal decongestion, go get the stuff behind the counter. Don't tell the patient to go actually behind the counter because that'll freak out the pharmacist, but tell them to go actually ask for the real Sudafed because that's going to work much better for them. So just one thing to note. Again, here's an example of Sudafed PE. This is bad stuff. Do not tell patients to get this. Notice here it's non-drowsy. Again, this is a stimulant sort of medication, so same thing goes for pseudoephedrine. These are non-drowsy. Again, this is to try to differentiate it between something like an antihistamine, which again, normally people think cough and cold medication is going to make you sleepy. That's how they kind of differentiate between those two there. Okay, next we have our antitussive or expectorant agents. So antitussive meaning keeping you from coughing, expectorant meaning helping you to get up and expel mucus. So as terms of cough, we have a lot of cough receptors in the respiratory tract, and normally they will respond to things like chemical or mechanical irritants, and the main thing it's trying to do is to get rid of stuff in the respiratory tract to keep the lungs nice and clean as best as possible. You actually find that there is a very complicated sort of neural relay that occurs here with the brainstem, and it's actually what you end up finding is that opioids, things like morphine and heroin, can actually suppress that brainstem reflex, and actually works as a very good antitussive. That'll become important in a second when we're talking about a derivative of those agents there. But main things you worry about here is that if you have patients who are coughing a lot, it can sometimes be bothersome. It can keep them awake at night. Occasionally, you can find patients have sometimes given themselves like a pneumothorax before because of over coughing, or they've had all kinds of bad issues from this. And so, because of that, and not only can things like syncope occur rarely, rib fractures. Obviously, if your significant others in the bed next to you, they're going to want to throw you out because you're coughing all night long. So the main goal we're shooting for here is to try to reduce that number and severity of episodes, and then try to prevent any complications. So one agent here, this is going to be prescription only. These are called benzonatate or Tessalon pearls. You can kind of see where they got the name from there. This one's interesting because it works by basically anesthetizing those stress receptors in the lungs. So even though normally you would have something that may trigger that cough reflex, these actually anesthetize that and makes it so that signal never gets sent up to the brainstem here, right? So very good for relief of non-productive coughs. Again, if you have a ton of mucus down there in the lungs, it's not going to help you get rid of it. It's going to just maybe prevent you from coughing some of it up, which can be problematic if it's full of bacteria, right? Big things to note with this one. This is something you cannot chew or cut, because once you open that gel caplet up, then you can risk having things like anesthetizing effects on the actual oral mucosa and the tongue. So tell patients not to chew it up. Make sure kids do not get into it. Actually, kids getting into this stuff can actually cause pretty significant respiratory and CNS depression. So that can be a very dangerous sort of pediatric ingestion. But for adults who accidentally chew into it, mainly oral numbness is the main problem you're going to see with that. The other more common one you're going to run into is going to be dextromethorphan, which you find in a lot of products like Robitussin or Delsum. And so basically this is a derivative of the opioids. It doesn't have any opioid effects itself. It doesn't really cause a lot of analgesia. However, it does suppress that medullary cough center, right? So that way prevents, even though the signals are being transmitted from, say, the respiratory tract up, it never triggers off that cough response there, which is good. So other problems you can see with this, though, especially with higher doses, you can see agitation, excitement, confusion. And so this is usually seen with higher doses, which normally try to avoid in most patients. And so here, noticing you can also run into some problems that the patients are on antidepressant medications, because you can cause risk for serotonin syndrome. This is rare, but it could be seen if you have maybe a patient with a history of depression and they're coming in, they're really getting kind of agitated or excited after taking something for their cough. This may be something you want to think about. Something like dextromethorphan can be causing this. And definitely avoid taking with any kind of MAOI. We'll talk much more about those when we get into the behavioral section later on in your curriculum. If anyone can actually tell me why I put Bender the robot here holding a bottle of Robitussin, I will, if you email me, the first person email me why I put this association here with the correct answer, I will give you one free test answer. So just FYI, I want to see who's actually watching this, who's actually listening, right? Anyway, one other drug here, this is more of an expectorant, so this is guaifenesin. This is actually good as a mucolytic, meaning it's going to start to break down mucus and cause you to cough that up. So loosens mucus, will decrease viscosity. The big thing to note with this is that you have to drink it with lots of water, right? So if you're kind of dehydrated just from being sick and you're trying to take this, it doesn't really do a whole lot for that. You want to make sure the mucus is nice and moist to decrease that viscosity, to loosen it up, now we can cough it out. So just be aware of that. Otherwise, no side effects, very well tolerated, maybe questionable efficacy, but can be useful for some patients. Again, drink plenty of fluids. And again, expect an increase in drainage. Let them know that, hey, they're going to see that. It may be problematic at first, but once they start to kind of get rid of it, then hopefully they'll kind of be back closer to baseline than they were before. Okay. So that's it for the ENT section. I think we're all pretty much caught up. Hopefully you guys are staying safe, staying dry, and hopefully have power so you can actually watch this. Otherwise, I will see you guys back on campus. Thanks a lot. Bye.